So, hello everyone. Thank you for joining us today for our NTDs Around the World webinar series. Today's session focuses on the investment landscape of neglected tropical disease and vector-borne disease research and development. My name is Hendrik Sai, and I will be moderating today's webinar. This webinar will last 90 minutes and is a joint initiative of Global Health EDCTP3 and FESTMIH. We are very pleased to bring together perspectives from FESTMIH, Impact Global Health EDCTP3, DG HERA, and Uniting to Combat NTDs. Marco Albonico will give welcome remarks and set the scene. Celine Ayer will talk about global funding trends in NTD R&D and the return on investment. Ana Duarte and Silvia Garcia on Global Health EDCPT3's role and contribution in tackling NTDs. Maria Daniel Loreno will talk about EU actions on vector-borne diseases, and Sheila Shava on the advocacy and investment case for NTD R&D. I will briefly introduce today's speakers. Marco Albonico is an experienced clinician from Italy with international expertise in public health, particularly the epidemiology and control of helminthic infections in Africa, Asia, and Latin America. He is a president of FESTMIH, a member of the Italian Network for NTDs, and a board member of the Italian Society of Tropical Medicine and Global Health. He previously worked with the WHO Department of Control of NTDs and has held academic roles as professor of parasitology at University of Turin and professor at Johns Hopkins Bloomberg School of Public Health. Celine Ayer is a senior analyst at Impact Global Health, where she leads a portfolio of work focused on estimating the impact of global health R&D investments by quantifying their health and economic returns. With over a decade of experience in health economic modeling, she specializes in evaluating innovation targeting neglected infectious diseases. Her work supports evidence-based policymaking and informs investment strategies across governments, philanthropic funders, and international organizations. Ana Duarte is the Operations and Policy Officer at Global Health EDCTP3. Dr. Duarte is a pharmacist and public health specialist by training with a background in health services and systems, emergencies and humanitarian crisis, and European health policy and law. Before joining Global Health EDCTP3 in 2024, she worked on health topics across the different services of the European Commission. Today, Dr. Duarte is responsible for the program in portfolio management and for the policy feedback related to Global Health EDCTP3 operational activities. Silvia Garcia is a scientific project officer at Global Health EDCTP3, joint undertaking contributing to the development and implementation of scientific priorities in NTDs, strengthening ethics and regulatory capacity in sub-Saharan Africa, and supporting the implementation of grant agreements under the European Horizon Framework. She previously served as senior manager for science policy and regulatory affairs at the European Federation of Pharmaceutical Industries and Associations, leading policy and advocacy across clinical research, preclinical development, and pharmacovigilance. She also brings experience from GlaxoSmithKline vaccine development and holds a degree in biomedical sciences from the University of Barcelona. Maria Daniel Lorero is an intelligence analyst in the Threats and MCM Intelligence Innovations and Funding Unit of DG HERA at the European Commission. In this role, she contributes to the environmental health threats team with a particular focus on medical countermeasures for vector-borne diseases. She also works on applications of artificial intelligence in health preparedness and response. Maria holds a bachelor's degree in computer engineering from Polytechnic Institute of Porto, a medical degree from the University of Porto, and a master's degree in international policy from the London School of Economics. She's currently pursuing a PhD in health data science at the University of Porto. Lastly, Sheila Shava. Dr. Shava is a senior technical advisor at the African Union Commission under Health Systems, Disease and Nutrition in the Directorate of Health and Humanitarian Affairs. She is the lead for TB, NTDs, and the Community Health Workers Initiative and possesses expertise in disease control programs with over 15 years of experience in public health policy formulation. Before joining the African Union, Dr. Shaba served as Program Officer, Laboratory Coordinator, and Researcher in programs under the Ministry of Health of Zambia, and her work informed the implementation of NTD control programs for lymphatic filariasis in the country. Dr. Shaba holds a PhD in parasitology from the University of Zambia and the University of Copenhagen, and a Master of Science in Infectious Disease from London School of Hygiene and Tropical Medicine. She's also a member of the ARISE Technical Advisory Group and an alumni of the Harvard Kennedy School of Government. So we would like to hear the questions from the audience. So your questions during the talks that will follow now. So please enter them in
negatively the NTD community, and particularly the R&D community. We all know what NTDs are. 20 more than 20 clinical conditions by different agents, helminth virus, fungi, some non-communicable, and plus the recent one, NOMA. But also here, I would like to show the pipeline of candidates for neglected diseases, like the vaccine, the drugs, the diagnostics, vector control products. And this is taken by the very nice report that probably in details in the next talk. It's a very informative and well done report on the impact of global health for R&D for NTDs. I would like just to take a step back, because I've been working with NTD even before the NTD were named as such. So I've been working WHO in the late 90s with the director of communicable diseases, whose name is Lorenzo Savioli, and together himself with Peter Roth, as you can see the picture here, David Molyneux, and other scientists created a group of founders that they defined in 2005 conference in Berlin, the brand Neglected Tropical Diseases. Then in 2026, the preventive chemotherapy strategy started, was launched by WHO. Then you know that the PLOS NTD journal was also created right after that. And you also know that the 2012 year marked the London Declaration for NTDs that gathered together manufacturer, drug companies, NGO, endemic countries, international agency, and you can see here one of the most important donors of this private partnership, Bill Gates, that is still funding many a very important component of R&D for NTDs. Why they are neglected? We all know that they don't get the right attention. They are affecting neglected communities. In high-income countries are no longer a public health problem, so there are neglected health rights. Low and middle-income countries are also less a priority in this globalized world. So we can talk also of neglected countries, but especially here we concentrate on poor investment in research and development. So this is an old statement, less than new drugs in the last 30 years. Now we will see that the picture is slightly changes also somehow in a positive way, but still neglected. We can talk about the neglected diagnostic and neglected medicines. Just one slide on climate change. We will know that in Europe, but worldwide, there will be a rising in temperatures, more frequent extreme meteorological events, hotter and drier summers, and increase of rainfalls and floods, especially in Europe and in the north. And this will trigger multiplication and importation also of vectors, and here is a CDC recent map of Aedes invasive mosquitoes. In the small blue circle, there are the Aedes aegypti, which is still not common, luckily, in Europe. But then you can see the Aedes albopictus and also other Aedes from Asia that are coming into Europe very rapidly, and this creates conditions for vector-borne diseases will be dealt with in the next talks, like chikungunya, especially in Italy, was hit by important epidemics, autochthonous cases. Dengue, we all know, is a global emergency with 4 million cases. But some cases can be also autochthonous, not many. Luckily, we had some autochthonous cases in Italy last year, many imported cases, as well as West Nile, which is also endemic, and also northern Italy. We had a number of cases of autochthonous of West Nile virus with serious consequences in some people. So all this to say that climate change will influence, is already influencing, and will influence the panorama and the landscape of transmission of several diseases, including the neglected tropical, which are no more tropical because the climate is changing. So probably we ought to change the name and take the T out of the acronym. Another slide just to highlight the importance of travels. After the COVID that almost stopped all the travels, ITA, the international tourist arrival, increased again. We are now 1.4, 1.5 billion travels, many in Europe, in Africa as well. But then we have travel for tourists and for different reasons, for work, but also we have migrants, and migrants are a special fragile population which comes to North America, comes to Europe, seeking refugee or work or job, so they're escaping from war or other very critical geopolitical situations. So their rights is not always respected, and for example, in Italy there is a big there are several problems of integration, screening of migrants for several diseases for their own health, and then improve their access to health, which sometimes is denied for several reasons that you all know. So there are already still big inequalities between different citizenships and populations in Europe and elsewhere. So this triggers also, for example, the Chagas disease has been confined in Latin America. Now with the migration in Europe, we are expecting about 100,000 cases of Chagas disease. Most of them are underdiagnosed, and therefore the sentinel and alerts should be high for Chagas, for schistosomiasis, for other diseases, arboviruses. We just seen the vectors. Schistosomiasis, you are also aware of the autochthonous cases from Corsica, the local transmission. So there are signals that these diseases are coming back, emerging again in Europe. Couple of global challenges which are impacting heavily the scenario of NTD as well. One is economic. You know that last year the U.S. administration decided to cut the funds for USAID, which resulted, it could result, according to this analysis, in many millions of more deaths by 2030 of from all age deaths, including more for 5.5 million deaths in children. The cascade, the negative cascade, hit also some European countries which reduced the funding for ODA, and the U.S. hikes, U.S. tariff and duties on healthcare is also impacting several items, vaccine, drugs, and so there is a sort of movement that resists this trend. African countries are forced now to reinvent or redesign, rethink of funding and to be more self-reliable, but this is happening in such a very short time that are really suffering from this sudden reduction of funding from donors. The second challenge, as we all know.
One more minute, Marco.
Sure, I'm about to finish. The second challenge is are conflicts and war. These are all forgotten or less forgotten conflicts worldwide. You know, the impact on health system. A recent Lancet article said 1% increase in military spending results in almost 1% drop in public health spending. So this is there is not much to comment about it, but we have to be aware and to be resilient in this such a situation. So this takes an impact on the funding. This is the trend in the last, say, 5 or 6 years. There is a decreasing trend for NTDs from the top 10 donors up to not only for the COVID, but also is decreasing also after that. And then there are need of about $500 million per year between 26 and 2030 to control and reach the SDG, which are hard to meet in the present situation. A positive, and we will see more positive news. WHO is producing, publishing a blueprint. Is about to be published in the next few months. So with showing the progress of NTD medicine and the vaccine and the diagnostics. And then I just finish in underline the importance of partnership and collaboration. We are having two very important events in 2027. The FESTMIH is organizing with IS Global the ECTMI Congress in Barcelona, and then the EDCP is organizing the forum in Madrid in 2027 in Spain. So these are events that triggers partnership, triggers the youth organization and energy for many global health issues, including control and research and development for NTDs. Thank you very much. I'm done, and I leave the the word to the next speaker. Thank you.
Thank you so much, Marco, for this great overview. Our next speaker is Celine Ayer.
Yes. I cannot share my screen. Wait, now it's starting.
Marco, can you unshare your screen? No.
Yeah.
Perfect.
Can you see my slide?
We
Okay,
can see it.
so
If you put it in speaker, yeah, perfect.
yeah, okay, perfect. So good afternoon, everyone. Thank you, Hendrik, for the introduction and for the opportunity to speak today about global health R&D investment. So I will first walk you through the latest funding figures we have at Impact Global Health, and then discuss the return this investment generates both globally and domestically. So at Impact Global Health, we collect annual data on investment in global health R&D through our G-Finder survey. We focus on three main areas: neglected disease, emerging infectious disease, and women's health. Our definition of neglected diseases includes most of the neglected tropical disease from the WHO list, and also the big three, so HIV, TB, and malaria. So overall, funding for global health R&D declined by 6% in 2024, but that was mostly due to reduced COVID funding. Funding for neglected disease fell by 3%, and almost all of that drop came from reduced HIV funding. And then if we looked more specifically at neglected tropical disease, funding stayed mostly flat in 2024 at around 420 million. Over the last 10 years, funding has only grown by a little, by about 0.4% per year on average. But one positive sign is the growth in private sector R&D funding. The last 3 years were the biggest years on record for private investment, especially for dengue. So what will 2025 look like? All of the data that I just showed you predict the cuts ordered by the Trump administration in 2025. We do not yet know the full impact of these cuts, but we can expect them to be significant. Since 2007, when we started collecting investment data, the US government has provided at least 47% of global health R&D funding, contributing to over 54 billion. So it's really by far the largest global health R&D funder. And essentially, almost all of these 54 billion came from 5 agencies: the NIH, BARDA, Biomedical Advanced Research and Development Authority, the DOT, Department of Defense, and then USAID and CDC. NIH is the main US government funder for R&D, for research and development, accounting for 77% of USG funding, US government funding. And is also the largest single funder globally, representing 38% of total global health R&D funding. We estimate the NIH cuts to be close to 500 million in 2025. Where do we expect to see this impact? Well, NIH primarily funds basic and early stage research, meaning the impact of these cuts on the flow of products is likely to be felt more in the long term. Some diseases are also far more dependent on US funding than others. For neglected tropical disease specifically, 38% of all R&D funding comes from the US government. So this means that any reduction in US funding is likely to have a direct impact on the development of new tools and products for this disease. But as I mentioned earlier, we will have a better understanding of the impact in a few months when we publish our 2025 report. But beyond these immediate funding cuts, there's also a bigger question. How do we show the value of investing in global health R&D at a time when these investments are under growing pressure? And in recent years at Impact Global Health, we have focused more and more on measuring the impact of investing in global health R&D. So one of the first questions we asked was, what is the societal return of investing in neglected disease R&D? So to calculate the societal return from the last 20 years of global health investment in neglected disease R&D, we calculated the life saved and DALYs averted, so disability adjusted life years, between 2000 and 2040 from a set of disease product combination, which you can see on the table. So these products were based on specific criteria, which you can find in the report, but basically they needed to be approved between 1999 and 2022 when the study was conducted, or expected to be launched before 2040. Also, this disease needed to be feasible for modeling, so very small NTDs weren't included due to the lack of data and high uncertainty. We then estimated the economic values of these DALYs averted using the value of a statistical life approach, which basically reflects how society values reduction in mortality risk to get the societal value of these health gains. So these products are estimated to save 40 million lives and avert 2.83 billion DALYs by 2014. The societal value of these health gains were estimated at $49 trillion. And this value comes from improved health outcomes and is largely concentrated where the burden of neglected disease is the highest. So Sub-Saharan Africa, South and Southeast Asia. To estimate the societal return, we divided the total net benefit, so the societal value of those DALYs, added some productivity gains and subtracted the cost of rolling out these products. And we divided that by the total R&D investment. We found that every dollar invested in neglected disease R&D generates $405 to society. But in the current geopolitical context, it's becoming increasingly important to not only articulate the societal return of global health R&D investment, but also its domestic value. And this is exactly what we show in our latest report, that investing in global health R&D doesn't just save lives abroad, but it also delivers tangible returns in high-income countries. So again, using our GFinder survey data, we estimate that between 2007 and 2023, governments from high-income countries have invested around $71 billion in global health R&D. This isn't just for neglected disease, but also covers women's health and emerging infectious disease. Team Europe contributed close to $10 billion over this period and has been one of the main funders with the US and the UK. And one finding that came out and was striking is that out of those 71 billion invested, we found that 90% stayed within institutions in high-income countries. This has important implications because when funding stays within institutions in high-income countries, it fuels local economies, it boosts GDP, supports high-quality jobs, catalyzes private sector investment, and creates spillover effect into other sectors. So for Team Europe specifically, we estimate that global health R&D has generated around $57 billion in economic activity and supports more than 70,000 jobs. Over the coming decade, it also has the potential to catalyze close to $30 billion in private sector investment. These numbers are quite significant, and if you are interested in knowing more about the specific country's contribution, how much of it stays within its own country and the benefit it generates, please have a look at our interactive map that is available on our website. Another major benefit of investing in global health R&D is the innovation spillover effect. This is often overlooked, but we see it clearly. Research originally focused on disease prevalent in low and middle income countries has repeatedly produced innovation that were later adapted, repurposed, or scaled to benefit high income countries. And we clearly saw this during the COVID-19 pandemic when existing vaccine platforms such as ChAdOx were rapidly repurposed to develop a COVID-19 vaccine. So we have identified 33 of such innovation, which you can explore in our online tracker that is also available on our website. And for some of these innovations, we have gone a step further and quantified their health and economic impact in high-income countries. So in the US, in the UK, in Europe, and in Japan. And to give a few examples, the AS01 adjuvant, originally developed for the RTSS malaria vaccine, is now used in the shingle vaccine known as Shingrix to protect aging population in high-income countries. We estimate that by 2050, Shingrix will avert 17 million cases in Europe and save around $11 billion for the health system. Another example is the BCG vaccine. It was developed over a century ago to prevent tuberculosis and is now used as a bladder cancer treatment in HICS. We estimate that it will avert more than 400,000 recurrences in Europe and save roughly $2 billion to the health systems. So these are just few examples to show that innovation from global health R&D investment can ultimately benefit everyone, save lives, and ease pressure on health system also in high-income countries. So we have discussed the benefit to high-income countries, but what are the implications for LMIC? Today, only 10% of funding from high-income countries' government reaches low and middle-income countries, with the biggest recipient by large being South Africa. There is clearly a need to build a more distributed, equitable, and resilient R&D ecosystem. And this is where LMIC governments have a pivotal role to play by investing in research infrastructure, manufacturing capacity, human capital, regulatory system. Strengthening this foundation would help retain funding within these countries and allow them to benefit from the same scientific and economic gains that high-income countries have seen from sustained investment in R&D. There is also growing recognition that we need to rethink how global health R&D is financed. Traditional funding approach limit opportunities for local leadership. These can include, but they are not limited to, match co-funding from LMIC institutions, prioritization to long-term capacity building. And this is where also PDPs, product development partnerships, have a critical role to play. They should be able to fund the unfunded mandate, as does the EDCTP. So going beyond product development to support LMIC-led trial, technology transfer, regulatory harmonization, and regional leaderships. Ultimately, these approaches are about broadening the base and building a stronger, more resilient R&D ecosystem, one that can better respond to future health challenges while creating shared scientific, health, and economic benefits across regions. So the takeaways are clear. Global health R&D delivers measurable returns in health, economic growth, and innovation spillovers. These benefits flow back to fund the countries and strengthen pandemic preparedness and national security. With the US and the UK stepping down, Europe has an opportunity to lead and enable a robust R&D ecosystem. The fact that only 10% of funding reaches LMIC directly points to the need for a more distributed and resilient R&D ecosystem. Thank you. I'll stop sharing.
Thank you very much, Celine. I'm personally impressed by these numbers of return investing into NTDs. Our next speakers are Ana Duarte and Silvia Garcia.
Well, thank you very much for the kind introduction and for the collaborative meeting that we're having here today. So you'll have me presenting part of the content in terms of Global Health EDCTP3, and then Sylvia will complement with the more NTD specific content. So I hope everybody can hear me well. Sylvia, if you don't mind going to the next slide. So Global Health EDCTP3, also known as the African-European Research Partnership on Infectious Diseases, maybe most of you may know what it is already, but I will do a small introduction, and also I will try to connect a bit with some things that were said by the previous speakers. So next slide. So about Global Health EDCTP3, we're We were established in 2021. We are the largest research funding partnership between Europe and Africa. And we are composed by 16 European and 33 sub-Saharan African countries that make part of our composition, whether the other part is represented by the European Commission, representing the European Union. So that's the meaning of our partnership, this public-public collaboration between the EU and the member states, both of European and African countries. We build on the success of our predecessors, so that's EDCTP 1 and 2. And in overall, we're trying to contribute to the Sustainable Development Goals, the EU Global Health Strategy, the Strategy for European Life Science, the Global Gateway, the EU Agenda, Innovation Agenda, and also the 2063 Agenda. And many other priorities. So we are also connecting with what was explained by the previous speaker in terms of Team Europe initiative and other initiatives that connect the EU to the African continent. Next slide. So in terms of our strategic approach, our vision is to reduce the individual, social, and economic burden of poverty-related infectious diseases. And this includes, in the context of our meeting today, neglected infectious diseases. And you will see in our strategic research agenda, we refer to NTDs as neglected infectious diseases. As Marco was mentioning, the T in tropical now may not be as relevant. And already in 2021, we thought from that perspective of calling it neglected infectious diseases, but also emerging and remerging infectious diseases that affect sub-Saharan Africa. So our overall mission is to lower the mortality and morbidity in sub-Saharan Africa, and we do this through collaborative research, capacity strengthening, and also accelerating the development, evaluation, and implementation of solutions. We have a dual aspect in terms of our investments. We have both projects. So these are projects that are direct grants from us. And then we also have investments from the member states that come and provide the complementary money of this partnership, that they invest themselves for the same objectives as the program and then count as investment for the program. And then we also have contributions for contributing partners that either invest directly in our calls for proposals or that invest in the projects individually. And then, of course, while these projects are selected through open calls, they bring different partners, and this is how the cross collaboration is done, as we require to have participation from north and south to ensure that there's this true nature of the partnership, and that this is these values are represented in the projects. Next slide, please. So the strategic approach is mainly focused on this advancement of biomedical interventions. This is the biggest, the majority of projects that we fund is indeed on the first aspect. Then these projects usually have a research capacity development, or we may also fund research capacity development through coordination of support actions. And of course, this also serves to enhance the coordination and then strengthen the capacity for response, and also further networking to build more partnerships and strategic alliances. Next slide, please. So in terms of scope, I would like to explain, because although we're going to focus today on NTDs, our focus is a bit broader. So we also have malaria, HIV, and tuberculosis, which were the initial focus of the earlier programs, and then neglected infectious diseases came in together with emerging and remerging infections, lower respiratory tract infections, diarrheal diseases. And in the context of having more cross-cutting aspects, we have also embedded AMR, digital health solutions, and climate crisis, climate-sensitive infections. And actually, NTDs do fall into these three cross-cutting areas, and I will explain a bit more later how they're also embedded there. Our major focus is on the later stages of clinical evaluation, and also also we try to embed as much as possible as specific vulnerable population groups, and you will see this later on when I present the specific NTD portfolio. Next slide, please. So in terms of our portfolio, we currently have 438 million invested through 109 projects, and these cover a wealth of areas, as mentioned before. And these are divided then into research actions and support actions, as we also mentioned before. Out of these, we have 49 projects involving clinical trials, 35 that contribute to health security worldwide, 34 projects that focus on medical devices development, and then 44 on implementation research, because these later stages and improving the access, implementation research has been proven to be a tool that has helped us in improving access, for example, studying acceptability, uptake, and other aspects related to deployment of solutions. And then we also have 47 projects that address the specific need of minors, meaning those under 18, and 36 the needs of children. And this is quite important for us, considering the focus on the vulnerable populations. Next slide, please. So if we look at our entire portfolio, you see that currently, so with today's data, or better, the one of March 2026, but it's very much up to date, the biggest investment actually focuses on malaria, immediately followed by neglected infectious diseases. So this to show that although malaria, HIV, and tuberculosis were at the CERN of the first program, actually priorities have shifted quite a lot to feature neglected infectious diseases. And you will see later from the presentation of Sylvia that although some of our topics are more cross-cutting, and we do have tried to capture based on specific cross-cutting needs, neglected infectious diseases do come up a lot, and successfully manage to obtain grants even in cross-cutting topics. When we discuss the funding according by intervention type, currently the most funded are therapies and diagnostics, followed by vaccines. But also to let you know that we are currently implementing Work Program 2025 from the sense of signing grant agreements, and we are also evaluating Work Program 2026, meaning that further projects, actually around 80, and if you think about it, it's quite a lot in 2 years because we are currently at 109, sorry, 80 in the next year and a half will be signed and will add to this composition, namely, for example, neglected infectious diseases, vaccines. Next slide, please. So now going a bit more in detail to the NTDs portfolio. So far I tried to explain to you how the neglected infectious disease area features in our portfolio as a whole, and you've seen that is a very relevant part of our portfolio. So currently with this 90 million invested from our side, when we say 90 million invested from our side, is really just in terms of projects, what they get as the contribution from the joint undertaking. They may be getting additional funding, for example, to fund costs that are adjacent, still covered in the project, but are not directly funded by us. So this is really just our contribution into these projects. And for example, as I mentioned here, we're currently still signing projects under vaccines. So the majority that is covered is actually therapy. So we currently covered 62 million in NTD therapies, and Sylvia will give some of these examples later on. And then we covered 20 million in diagnostics and 6 million in the surveillance tools, and other prevention tools cover aspects, for example, related to vector control. Of course, that when we're presenting the main area covered. So, for example, therapies may also cover some vector control tools, etc., if they have integrated approaches. But we're showcasing the main intervention of each project, so their main focus. what is interesting to showcase, it's because unlike some of our other investment areas where we have a bigger focus in phase 3 and 4 of clinical trials, because we invest in such a variety number of NTDs, and the pipelines for these NTDs are also very different. The phases of investment actually vary. So we do have some phase 2, phase 3, and then some phase 4. For your understanding, we only allow phase 2 investments if there is a clear lack of pipeline for that disease and for that specific intervention on later stage. So phase 2 is not late stage, and it's only allowed in the case of a specific public health need. And a similar aspect is seen for medical devices, but though there we do have some more that are in final validation and product launch phase. In terms of target population, and I explained this, that is quite important for us to ensure that we are addressing vulnerable populations. So we do have some older children and adolescents, but as you can see, for example, younger populations are not as easy to target with these interventions. And this is most likely also because of the phases of development and the diversity in the pipelines as explained. And then if we go to the last slide from my part, before I move on to Sylvia, I wanted to explain a bit this aspect of the cross-cutting areas and how we are addressing them, because this is more the novelty of EDCTP3 in comparison to the previous program. So, for example, in terms of antimicrobial resistance, and we define antimicrobial resistance for the purpose of portfolio analysis as being broad and also including parasites. And in this case, we have STOP 2030. I don't know if you're familiar with STOP projects. Sylvia will also introduce a bit later, but this project follows STOP 1 and 2 from EDCTP 1 and 2, and then we also have 3SI control, and these are projects that are implementing phase 4 trials on fixed dose co-formulation of albendazole and ivermectin, and they are trying to lessen the risk of resistance emergence in soil transmitted helminthisis. And then we have FAME, that is one of these phase 2 projects that is trying to develop a safe alternative to eliminate onchocercasis, also in the context of resistance. Then in terms of climate and health, for example, we have projects such as EpiGen Ethiopia, that is a genomic surveillance project that tries to build a scalable pathogen genomic epidemiology in Ethiopia, including on the intersection of climate and health. DD, you will see it twice because it's both on climate and also digital health technologies, that is trying to look into this digital dashboards in diagnostic innovations, and they also are trying to do this interoperability of climate and health databases. And then impacting, that is a vector-related, control-related project, and the surveillance that is also embedding the aspects of climate. And then finally, we have the digital health aspect. In terms of digital health, we have, for example, eWorm, that is also addressing soil-transmitted helminthisis, and is looking into developing an open-source virtual training and assessment tool for diagnostics of NTDs. So all of these information, if you type the names of the projects, you can find more information on them. And then the other ones I mentioned, but for example, with the multiplex AI, we also have intelligence autonomous microscoping for parasite infections, and also AI-driven applications for skin NTDs. And this is skin care that Sylvia will also introduce later. So thank you. And now it goes back to you, Sylvia.
Thank you. And sorry, I forgot to unmute myself. So I'm unmuting myself and resharing the slides.
In the interest of time, perhaps 5 minutes. If that is okay.
It'll be fine. Thank you, Hendrik.
I think, tell me if you can see my slides now.
We can see them.
Yeah.
Okay, perfect. How many time I have to accelerate?
5 minutes.
5, okay. So thanks, Hannah, for the good overview, and thanks to the host for inviting us today. It's my pleasure to be engaged on these discussions on NTDs. So, following the presentation of Anna, EDCTP3 has been extensively funding neglected infection diseases since the beginning of the World Program. So since 2022 and beyond. So NTDs has been part of these cross-cutting topics for awarded criteria, and you can see some of them were embedded on promoting implementation research results, genomic epidemiology, digital health solutions, and so on and so forth. We had also targeted topics. So in the work program on 2024 was covering the accelerated development of therapeutics and non-pharmaceutical intervention against NTDs. So as a result, we awarded the 8 projects here, and I will pick up afterwards a few of them for your better understanding. Then following the 2024 work program on 2025, we had, and Anna also mentioned about this, the topic called on accelerating the development of prophylactic vaccines against NTDs. This is currently, and she mentioned as well, this is currently ongoing for grant agreement signature. I can already disclose that we have 2 of them already signed and 1 that is almost final. And these vaccine projects around dengue and chikungunya. So we have selected, as you have seen, there is a lot to pick up. There are a lot of interesting projects, but we wanted to bring you some or showcase some of the most important projects in the sense, most important in the sense of we have picked up 3 projects related to innovative setting, target population, and or co-funding model, but it has been very difficult to select. So the first one is skincare. So the project aims to develop a smartphone application using artificial intelligence to support diagnosis of skin conditions linked to NTDs. It's covering currently 12 diseases. The proposal was developed to tackle the 2 billion people having skin conditions linked to NTDs and the shortage of specialist dermatologists in sub-Saharan Africa. The project contributions to be expected are to create this artificial intelligence smart phone application that can be used in primary care settings to characterize the skin lesions, to provide a diagnosis to guide subsequent care, and to ensure that patients receive a rapid diagnosis, and also to reduce the risk of further transmission within the community. It is going to be the largest data set of skin NTDs public, and also it will enable the mapping and geolocation of these skin NTDs. The consortium is currently collaborating with WHO. I added on the slide on the third link a publication on the journal Investigative Dermatology, where WHO explains their application. So they have developed as well a skin NTD application. They're collaborating together. In order not to take a lot of time, you can see that the coordinators, the Universidad Politécnica de Madrid, you can see here the countries participating in the project. The EU contribution is around 5 million euros, and the project started on 2025 and will finalize in 2030. The second project selected is Wings for FGS. So this is in female genital schistosomiasis. So the aim for the project to contribute is to develop a 2-step test community screening, to conduct a clinical trial to assess if adding the anti-inflammatory drugs to praziquantel will improve healing, and to identify barriers and enablers for integrating this female genital schistosomiasis in the woman's healthcare service. So the challenge for the proposal to be developed was that FGS affects 50 million women that are often misdiagnosed as a sexual transmitted infection, and this causes stigma and delay care. The coordinator of this project is the London School of Hygiene and Tropical Medicine Royal Charter based in UK. You can see here the participating countries. EU contributed to around 5 million euros, and the project started in 2025 and will be finalized in 2029. And we have added for each of the projects their specific website that it's a deliverable for our projects, and also the information, a summary, and the outcomes achieved so far on the European database CORDIS. And last but not least, we have PICAP Stop 2030. My colleague Anna has already introduced the project. The project aimed to develop a new fixed-dose combination tablet for albendazole and ivermectin against soil-transmitted helminths, so for the worms infections. So when the proposal was developed, it was known that the current treatments had their limitations against certain parasites, and it wanted in joint forces with WHO to eliminate the worms infections in children by 2030. The expected contributions for this project is to accelerate the implementation of this fixed dose combination, so using a single pill treatment. That was already known that it was proved to be significantly more efficacy or against the treatment of the trichuriasis, and to generate the evidence to inform the WHO guidance and be translated in national policy decisions. So you can see here the coordinator is Laboratorios Liconsa, SA in Spain, the countries participating. The EU contribution has been 3.5 million, around 3.5 million. And the project started in 2023 and it aimed to be finalized in 2026. However, there has been an extension and will finalize in 1 year more. And here, what I want to highlight is that the consortium itself has brought some co-funding. So it contributes, they are contributing themselves with 1.5 million to cover project costs with their own resources. And this is very important to highlight. And as colleagues have mentioned on their presentations as well, due to the current geopolitical situation and the cut on the global health funds, it's very important and something that EDCTP3 is supporting, that partners more and more brings co-funding to the projects. This can be in kind or in cash contributions to stabilize or to strengthen the financial capability of the project. And in order to motivate or to engage the consortium in the proposals, we have developed a new concept that is the contributing partner concept that Anna also introduced in her presentation. And this is applicable for legal entities. This can be private, international organizations. They can be industry, biotech, that will co-fund the project with the consortium, or public research or academia that are not members of the EDCTP member countries association. And with that, well, maybe just to mention that also to motivate or to engage this contributing partners concept, we are assessing positively in the evaluation. So when the consortium is bringing contributing partners under the impact criterion for stage 1 and stage 2, and also for the implementation criterion under the stage 2. So this is something that the EDCTP3 would like to work more and more, and that the partners engage with. So with that, over back to the presenter.
Thank you so much for giving us that glimpse into EDCTP3 projects.
Hello. I hope you guys can hear me.
Yes, we can hear you. Go ahead.
Thank you so much. Thank you for having me. My name is Maria Loureiro, and I work for DG HERA in the European Commission. This is the Health Emergency Preparedness and Response Authority. And today I'm going to be telling you a little bit about what we are doing in the domain of vector-borne diseases. We can go to the next slide. So just as an introduction, for those of you who don't know about HERA, we were created during the COVID pandemic with the objective of strengthening Europe's ability to prevent, detect, and respond to cross-border health emergencies by ensuring the availability and access to medical countermeasures. Here, for us, medical countermeasures encompasses all medicines, medical devices, PPE, treatments, diagnostics, everything, and all goods and services that can be aimed at fighting these cross-border threats to health. And at HERA, the idea is really to have a whole value chain approach to ensuring the availability of these medical countermeasures. What that means is we perform intelligence gathering and analysis, so both on the threats, but also on the medical countermeasures themselves. For example, we do pipeline analysis. Then we support research and development. We support clinical trials. We work with EMA also in supporting the access to market. And then we also have certain instruments available to us with member states to provide support to manufacturing, procurement, for example, in the form of joint procurement with the member states, and then distribution and stockpiling according to EU and member state needs. We can go to the next slide. So recently, in July of 2025, we launched our medical countermeasure strategy, which is an EU framework to anticipate the health threats that we foresee that will be more priority for the future and ensure the timely access to vaccines, diagnostics, therapeutics, and other medical countermeasures in order to strengthen preparedness for future health emergencies, irrespective of their origin. The key actions that were proposed in this medical countermeasure strategy have to do with surveillance and intelligence systems, accelerating innovation and scaling up the manufacturing, ensuring this access, availability, and rapid deployment when needed of these medical countermeasures, driving the coordination and collaboration. So here, both with member states, but also, for example, civil-military cooperation between public and private sectors, and then also enhancing the population preparedness. Here, really strengthening both the EU workforce, investing in trainings also for this workforce, supporting EU response teams, etc. An interesting thing about this MCM strategy is that with it, we also announced the 2025 Health Threat Prioritization Assessment, where we organized in detail, we did an assessment of the types of cross-border threats to health that, in our opinion, pose a bigger threat for the EU in the years to come. And they were organized in 4 different groups. So respiratory and contact-based viruses with pandemic potential. So here, viruses with a history or a likelihood of causing large-scale outbreaks in the future. Then we can talk here also about antimicrobial resistance. So it's a rising concern, rising global concern, because the efficacy of existing treatments is diminishing. We also included armed conflict-related threats, so chemical, radiological, biological, nuclear threats. And obviously, in the focus of this talk, vector-borne or animal reservoir viruses with epidemic potential. And if you go to the next slide, I can explain a little bit more in detail. So there you have, in this scale, you have highest priority and high priority threat. From the vector-borne viral families, we included in the highest priority Flaviviridae. So they're you can think of dengue, Zika, West Nile, so mainly mosquito-borne diseases. And then in the high priority threats, we included togaviridae. So here, think of chikungunya, also Rift Valley fever, and Crimean Congo hemorrhagic fever. So here already going into a different type of vector and including some tick-borne diseases. The criteria for this prioritization was based on the likelihood of occurrence, potential impact on public health, for example, severity, mortality, transmissibility, and cross-border spread. So basically how likely they are to quickly affect a large portion of Europe, availability of medical countermeasures, and EU's overall preparedness and response capacity. So this is, I think the last 2 points are particularly important. So this is not only a study on the epidemiological aspect, so how likely these diseases are to spread, their morbidity, mortality, etc., but also how ready the EU is to fight these threats. So if we lack medical countermeasures, if we lack vaccines, diagnostic tools, personal protective equipment, then we would place these threats higher, and they are more of a priority for us. This study was actually published as a staff working document in January of 2026. So if you're interested in taking a deeper look at this and perhaps also looking at the other threats that were selected, you can also do so. It's available online. Then if we go to the next slide. Also, as announced in the MCM strategy, we are going to publish towards the end of this year 5 MCM preparedness roadmaps for the EU. So here we're going to have at least one per threat group that I showed you now in from our threat prioritization exercise. And the idea here is really to look at different threat scenarios. So what can happen? What are the scenarios where each different type of threat is affecting the EU? And then looking also at national and EU plans and strategies to fight these threats. And from here, we derive a list of relevant medical countermeasures for the EU, which again is also going to be published. And we start looking a little bit at what is the medical countermeasure landscape and pipeline analysis. So here we look, if we think, for example, of vector-borne diseases, we'll see, okay, what are the vector surveillance tools that exist currently in the EU? How are they being used? Vector control tools. What are the detection and surveillance and outbreak investigation tools that exist that are being used by member states, that are announced in their plans? How do we do the clinical management of cases? What type of treatment do we use? How do we diagnose cases? What antiviral exists? What types of supportive therapy we need to have prepared? Is there vaccination ready? What are the digital tools do we have? So here we look kind of at the panorama of what exists already, what is being used, what is in the pipeline also. So for many of these vector-borne diseases, as you know, there are no vaccines or there are no treatments, but we also look at what is in the pipeline, both in early and in late development. And then we have an assessment at what are the gaps and vulnerabilities and at EU level. So really, as I was saying, where are there really no vaccines? Where are there no treatments? Where is the current PPE not enough? For which type of vectors are we not doing vector control, or where should we be doing more to avoid vector spread, or for example, mosquito overwintering in different EU member states? And from this analysis, we think of the current and potential interventions that we can do both at EU and member state level. And this is also going to be published towards the end of this year. If we go to the next slide, I'll tell you a little bit about the EU for Health actions that we already have on vector-borne diseases. These are in the 2025 work package. It's also expected that in 2026 we'll have some
actions on vector-borne diseases, but since the work package is still not, the work program is still not announced, we still don't know for sure what they will be. But for the 25 EU for Health actions, we have one on supporting the development of new diagnostic tests for vector-borne diseases. I can tell you already that we are funding at least 2 projects in this area. The evaluations have taken place. We are going to sign the contracts until the end of the year. And the idea with this action is really to mitigate the current underdiagnosis of certain vector-borne diseases in the EU. So from consulting with the experts, what we see is that there tends to be an underdiagnosis of this disease, both because diagnosis currently relies a lot on PCR, which is expensive and many times not readily available, but also because many clinicians are not trained to see these diseases, particularly in regions where they were not so common until recently, as we already talked about in other sessions. So the idea is to have a cassette test that would test for different diseases in a single cassette that can be readily available and cheap to use, so that hopefully we can have less misdiagnosis and underdiagnosis. Then we also have another action to support the development of dengue medical countermeasures. Here we mean treatments, actually, anticipating the growing needs of the union. So this is a 20 million contribution agreement. It's a contribution agreement to DNDi, Drugs for Neglected Diseases, with the support of Agence Française de Développement. And here there was a pipeline analysis that was conducted. So looking at all dengue treatments that were in the pipeline to see which ones were more advanced, which ones were more promising in terms of results. And then 2 of these molecules are going to be selected. And the idea here is that we are funding clinical trials and with the promise that if the molecules are successful, they would also be, the companies will also be submitting a marketing authorization within the EU. It's interesting here because we cooperate obviously with a lot of international partners, potentially in Brazil, India, etc., to run the clinical trials. And the discussions have been quite interesting, and we are also learning a lot from how these partners and in these countries dengue is managed. And then finally, we have also an action to support member states, EU member states, to scale up their national system for vector threat detection and control. So here a little bit focusing more on the vector aspect. This action was already evaluated. It's a joint action, so it's not a competitive action. Member states apply together with the project for vector surveillance and control. It was very interesting because, as you know, for EU for Health, it's actually not only EU member states that can apply, but there are other countries that can apply to EU for Health funds. And in fact, all the eligible countries applied. So we have 32 countries and 106 institutions that are going to be participating in this joint action. And the idea is really to strengthen and expand their national surveillance and control programs for disease vectors, to assess vector resistance, insecticide resistance, basically to reinforce their national laboratory capacities for vector control. And all of this will be done in cooperation both with DG Sante, that already has some actions on this, particularly on a specific vector control technique called sterile insect technique, but also with in close cooperation with ECDC, so European Center for Disease Prevention and Control, and their VectorNet group that already does a lot of work on vector surveillance and control. This action was also already evaluated.
Wrap up in the interest of time for the last speaker, maybe 30 seconds more.
Okay. So that's perfect because then we can go to Horizon Europe. So Horizon is another funding line that we also have that supports a little bit more early research projects. And here you can see that in the last years we've been funding vaccines, therapeutics, diagnostics, more perhaps on a global level. And here we have 31 million invested. We also invested close to 35 million with CEPI, which resulted in the funding of the first chikungunya vaccine actually to reach the market, called IXCHIK. And then I'll be super fast in the last slide, because actually our colleagues from EDCTP already presented, but through also Horizon Europe, we also fund EDCTP, and EDCTP, as was already said, has a lot of activities on vector-borne diseases. I will not be going further into this, but we're also a member of the EDCTP3 governing board, so we cooperate a lot on this. And that's my last slide then. So thank you so much for the chance to present here. Thank you.
Great, thank you so much. Our last speaker is Sheila Shava.
Good evening, good morning. Thank you so much for this opportunity to just share more on vector-borne diseases from an African perspective. It's interesting to see how much funding there is out there for vector-borne diseases in terms of research. I'm just trying to figure out how we can now actually connect all the dots with some of the challenges that we're facing from a continental perspective. So I'll focus on advocacy, human and financial capacity, and investment in R&D for vector-borne diseases, including NTDs. Okay, my slide is not moving. Okay. I don't know what is happening.
No problem. Press on your presentation, and normally then it will follow up.
Okay.
Click on your presentation.
Oh, yes. Yeah, it has. Yeah. So I think this is just showing the figures in terms of vector-borne diseases and NTDs in Africa. We know that 42% of the global burden of NTDs is in Africa. We know that 600 million people are affected by NTDs across 49 AU member states. 97% of the global deaths of malaria occur in Africa, and over 500,000 annual deaths on NTDs happen in Africa. We know that NTDs are both preventable and curable, but we still see that they still cause a lot of discomfort. They cause a lot of challenges on the continent. I will not go on the bottom slide. This is just analyzing more of the information. Now, the major vector-borne diseases that we're struggling with are malaria, lymphatic filariasis, onchocerciasis, heart, leishmaniasis, trachoma. We have dengue on the rise. We have the Rift Valley fever also on the rise. And even though we're seeing countries eliminating diseases such as LF, onco, sleeping sickness, a number of countries have actually eliminated this, but we tend to see a rise in malaria cases. So, for example, you see in the southern part of Africa, a number of countries were going towards the elimination 8. But with the climate change, we've seen that there's a resurgence of malaria on the continent, where some countries are actually reporting double the burden from previously. Countries that were on the blink of eliminating malaria in certain parts are now reporting increased number of cases. And so we can see that this is a challenge, and hence the need for us to really address this. So I think what are some of the current gaps that exist in terms of vector-borne diseases? I think these are general. We've had these challenges for some time now. The healthcare ratio, which still remains low. in most of our countries, especially in the rural areas. We still have challenges in really reaching the universal coverage needs in terms of health workers. We also have challenges in terms of capacity of training of health workers. Even those who are trained remain unemployed, whilst some of those that are trained and are good tend to move. So we see the brain drain crisis still continuing on the continent. And then we see the scarcity in terms of specialization for entomologists in rural areas and rural communities. We find that the number of entomologists that are present are very few. In some areas, we don't even have entomologists. And then we also have experienced lagging behind in terms of diagnostics for vector-borne diseases. We've seen NTDs have really lagged behind in terms of new technologies, new diagnostic tools. It's only now that we're seeing an increase in these tools for NTDs. In terms of field epidemiologists, again, we see that there's minimal surveillance, and most of it is under-resourced. Then we've been working with the Community Healthcare Workers Initiative, where the target was to deploy 2 million community healthcare workers across the continent. Now, we've made some progress in this area where we've deployed more than 1 million. But we still need to reach the 2 million target. We know that the 2 million target is not even sufficient, but it's a starting point for us. And so what are some of the strategic solutions that we've put in place or that we are actually implementing? We are training, deploying community healthcare workers. We've continued to do this since the decision was taken. And so we've had a number of countries train, recruit, and deploy CHWs. We've seen support from a number of our partners where even the community healthcare workers are incentivized. I think one of the challenges we faced was that these were voluntary positions and the community healthcare workers were not trained, but we're seeing a lot of training coming on board. We're also seeing the field epidemiologist training that is being established and rolled out in various countries where there's deliberate efforts to improve surveillance and outbreak response. We're also seeing the task shifting and sharing where non-specialist health workers in vector-borne diseases, diagnostic and prevention are actually supporting other initiatives. I think part of this is also working through the One Health approach where we're seeing other sectors such as the veterinary sector that usually do a lot of vector control for animals also support the health sector in ensuring that when they are doing vector-borne control of vectors for veterinary medicine, they are also supporting the health sector. We've seen, I think I talked about the incentives for the community healthcare workers, which we are actually seeing in rural communities, but also training specific to community healthcare workers within that geographical location, and the push to ensure that once the community healthcare workers are trained or the individuals are trained, they are not moving to the cities for better conditions, but they are actually linked or tied to the rural areas where they are trained. And then we're also seeing the competence-based curriculum where we are actually integrating vector-borne diseases models and climate health links into the medical and nursing schools on the continent. Now, in terms of investing in research and development, and it's good to see that there's a lot of work that is going on with EDCPT and the previous speaker. I think we can just build upon that and try to tap into that. So I think we have seen new tools and drug discoveries. The most recent one is the oral heart treatment, which is really has been a positive stride in terms of R&D for vector-borne diseases. We continue seeing the next-gen insecticide treatments for mosquitoes. We are seeing malaria vaccines that are coming on board, and we are also seeing the point-of-care diagnostics for core endemic NTD setting. I think we're seeing the resurgence of rapid testing for some of these NTDs coming on board now. In terms of local and regional manufacturing, we have the pharmaceutical manufacturing plan for Africa, which is being led by NEPAD. And we're seeing there's a lot of acceleration towards its implementation. We've seen the establishment of regional hubs for manufacturing of praziquantel, ivermectin, and artemisinin. We've also seen 70 to 90% drug import dependency through incentivized domestic production. And we've seen the recent launch of the Africa Medicines Agency that is going to fast track, vector-borne products registration and also support the regional harmonization of medicine. And to speak to this also, we've actually seen of course, a lot needs to be done. But right now, when you actually buy medicines locally, you see that some of these common drugs, cough mixtures, painkillers, you find that they're either produced within the country or they're produced from a regional country, which is really significant progress for the continent, because before, every time you are buying medicines or drugs, they would be coming from outside the country. So I think these are positive strides which we're supposed to build upon and advocate for and ensure that we actually move from just simple drugs to more sophisticated drugs in terms of regional and local manufacturing. And in terms of implementation and the health systems research, of course, there's need for operational research for integrated NTD, malaria, and HIV platform service deliveries. And I think this is critical because we've seen the change in the financial landscape. And so the drive is to try and using primary health care, integrate the service delivery so that we benefit from efficiency gains where the programs are implemented in an integrated manner rather than in a siloed approach. And we've also seen the climate vector-borne modeling prediction for outbreaks. This helps. Before, I think this was not something that was prioritized, but this helps us to predict outbreaks within the continent. We've also seen community engagement, creating awareness within the communities on the importance of vector-borne diseases, and also health economy, the investment case for vector-borne diseases, the benefits of prevention rather than going through treatment in terms of vector-borne diseases. And in terms of the Africa research ecosystem, we still have a long way to go in strengthening African researchers' leadership in vector-borne diseases trials. We have seen countries that have started doing this, but there's a lot that needs to be done to strengthen these capacities. And then we also working with the AU agencies, including AUD and NEPAD, Africa CDC, to coordinate research in this area, and also to support universities in ensuring that there's partnership with the industries for indigenous knowledge of integration of vector-borne diseases. So coming to how amplify the climate change and amplifying the vector-borne disease threats due to climate change. I think it's clear the impact that climate change has on vector-borne diseases, with the rising in temperatures, expanding the mosquitoes and vector inhabitants with higher altitudes and latitudes. We've seen the erratic rainfalls creating new breeding sites. We've seen flooding resulting into stagnation, but then with the flooding comes with, people being displaced, not accessing health services. We've seen droughts causing migration. I think as a result of droughts, we see people moving from areas where they can access health services to further up areas. They'll go further into the forests where now they're actually more exposed to vectors as these areas were previously not inhabited. We've also seen the long warm seasons that are leading to longer transmissions for malaria, dengue, and Rift Valley fever. And so the climate migration is leading to a higher spread of vector-borne diseases, even in areas that were initially not endemic, which were non-endemic. And so in response to that, we are working with countries to develop national adaptation plans. Now, the most interesting thing is that when we had a conversation with countries on whether they are developing climate mitigation plans, most countries indicated that they were doing that. But then when we asked if they were actually including NTDs and vector-borne diseases, this was not being done. And so our call has been, well, if you're developing climate mitigation plans, you need to ensure that you have vector-borne diseases and NTDs embedded in the plan itself, because that's the only way you'll be able to address them. So we are advocating for that and pushing and ensuring that countries prioritizes in their national mitigation plans. We've also advocating for the need to link meteorological data to disease surveillance. I think for a long time, there's been a disconnect in countries between the Ministry of Health and meteorology departments, because there hasn't been that deliberate effort to use the data to actually predict disease outbreaks. And so now one of the things that we're advocating for is to have this close linkages between the ministries of health and meteorological departments so that they can be able to predict disease outbreaks if there will be, for example, heavy rain patterns, then they are supposed to plan accordingly, because that means it will result into flooding. We've also seen vector control innovations that are coming up in terms of research. Again, research is something that we're building on, and there's need for more support in the countries to strengthen the research in terms of vector control. And for climate financing for health, we are strongly advocating for the Green Climate Fund and the adaptation to finance vector-borne diseases and ensure that they are eligible, so that when countries are advocating for the climate fund, they ensure that they prioritize vector-borne diseases. And I think also through the One Health approach, calling for integration between the various sectors, the animal sector, environmental sector, to ensure that we address the zoonotic diseases. And finally, a unified call to action. So Africa has knowledge, we have the frameworks, we have the policies, and there's need for agency. So what we need now, I think, is commitment. And some of these commitments have already been taken, but we need to implement them. So for example, we have the 15% Abuja Declaration that was made by the heads of state in 2001. And so there's need for countries to honor that and ensure that they allocate 15% of the national budgets to health. But we also know that even with that 15%, it is not sufficient. And so we're calling for more innovative ways of financing for health. And these include the introduction of sin taxes. Although most countries have this, the challenge that has been there is that even though tax is collected for health, once this tax is collected, it does not trickle down to the ministries of health. So they'll collect tax for cigarettes, alcohol, but this does not translate into benefiting the ministries of health. And one of the things that we're calling for is to ensure that as this tax is being collected, most of it should, at least a percentage, should be allocated to health. Of course, the need to increase the physical space through domestic resource mobilization, promoting health insurance infrastructure, and also the call for luxury tax to go towards health initiatives. And for the ministries of health, there is need to integrate vector-borne diseases services into primary health. I think for a long time we've seen a siloed approach where everything else is integrated, but we have not seen the deliberate move to integrate vector-borne diseases into the main architecture of primary health care in countries. So there's need for the ministries of health to do that and to also build on surveillance and laboratory capacity to ensure that these are resilient systems that are able to withstand the test of time. And for research institutes to lead Africa-centered vector-borne disease research and development, to train the next generation of African scientists and partner with other stakeholders when it comes to vector-borne diseases. For the private sector, I think the call is to co-invest in local manufacturing and also adapt the corporate social responsibility commitments for those endemic communities and support these initiatives. And for international partners, there's need for us to increase sustainable investment and honor the pledges towards vector-borne disease research and also support technology transfer to Africa. I think the technology transfer to Africa is quite a key thing because we've seen that where this has been done, it has been very beneficial. And so we're calling upon our partners to really ensure that this is something that is being prioritized. Thank you so much. And my sincere apologies. I'm under the weather, so my voice is not so good. I've got a terrible flu, so yeah. Thank you so much.
We'll feel better soon. Thank you so much, Dr. Schaba, for this excellent talk. And we are at time, and we had an ambitious agenda, a very interesting one. We'll skip the Q&A session today, but I would like to sincerely thank all of our panelists, Marco Albonico, Celine Ayer, Ana Duarte, Silvia Garcia, Maria Daniel Loureiro, and Sheila Shava for the presentations today. And I would also like to thank Global Health EDCTP3, including Augustin Martin and FESTMIH members Sophie Schneidler, Mayra Müller, and Antonia Walter for making this joint webinar possible, and of course all the participants for joining. Thank you again, and we look forward to welcoming you to a future session of our NTDs Around the World webinar series. Thank you.
Thank you. Thank you. That was very informative. Thank you for all. Thank you.
Thank you very much.
Thank you. Thank you.
Thank you. Bye.
Thank you. Bye.